Welcome to Leading Rural Healthcare, the podcast where we talk about the leaders shaping the future of healthcare in rural communities. I'm your host, Brendan Hurley. Today we're talking about Carrollton, Missouri, and Carroll County Memorial Hospital, a 25-bed critical access hospital that's taking an innovative approach to workforce and education. Through their partnerships with UMKC, a new student learning center, and advanced training tools, CCMH is working to build the next generation of rural health professionals while strengthening care for its community today. Joining me are two leaders from the hospital, Scott Thoreson, President and CEO, and Dr. Andy Horine, a family physician and the hospital's first Chief Medical Information Officer. Scott and Dr. Horine, welcome to Leading Rural Healthcare.
All right, thanks for having us.
Thanks, Brendan.
Yeah, so for listeners, again, who may not know either of you or Carroll County Memorial Hospital or even the community, tell us a bit about yourselves and the hospital. Scott, if you want to start off, that sounds great.
Sure. Yeah. Well, I've been here for 5 years already. It's coming up on 5 years. And actually, I'm going to be retiring in 3 months. So I have an extra kick in my step these days. So looking forward to that. But no, I came from Minnesota. I was born in Minnesota and spent time as a youngster in eastern North Dakota and northwestern Minnesota in very small towns, 5,000 in West Fargo, North Dakota, and about 250 people in the town that I actually went to high school in. Wow. So I was in a class of 31. Ended up being the class president. So they must have thought something about me and kind of went on from there to college in Moorhead, Minnesota, graduated from Moorhead State with a bachelor's in business administration. And then at the same time at Concordia College, they kindly took me in and I received basically a specialty in hospital administration. So did that. That kind of got me rolling, I guess. And eventually went on to the University of Minnesota to get my master's degree in hospital administration. And from there, I got, right after graduate school, got into the St. Cloud Hospital. It's a bigger hospital, kind of got my feet wet there. And then ultimately after St. Cloud, went on to a little town called Springfield, Minnesota in the southwest part of the state, about 2,200 people. And I was there for about 26 years. So was able to experience a lot of things there as part of the Mayo Clinic health system and also ran a second hospital there for a while in St. James. And unfortunately, my hospital in Springfield closed. And it was about the time COVID came around and then some budget reductions and so forth. And so my St. James hospital went to someone a little closer. So I was looking for another job at age 60 and Dr. Horine was kind enough to take me in. So I was really happy to have that work out for me. And it's been a wonderful last 5 years.
Well, congratulations on a very wide-spanning career in rural health, and we're going to get into that a little bit because it sounds like that's just been a part of your life for a long time. But with 3 months left, I don't expect I expect full transparency. Just tell me everything, and then you'll step out the door. But I'm excited for the conversation.
Thank you. As far as Andy's been here his whole life, and so he's probably better suited, I think, to talk about the hospital. We've been around for a little over 60 years. Andy isn't quite 60 yet, so he's got a ways to go yet. A little gray hair there. But...
Don't let the gray hairs fool you. I'm not that old. So I came to Carrollton in 2015, but that's really the middle of the story. So Carrollton, Missouri is my hometown. I literally got care at Carroll County Memorial Hospital when I was a child. My wife is from here as well, and so when we went off to get education, we always knew we wanted to come back home. That was always the plan. So I went to Northwest Missouri State in Maryville, Missouri for undergrad, then went to medical school at the A.T. Still University in Kirksville, Missouri.
Oh, nice.
Finishing that in 2012, I went to the University of Missouri-Columbia Family and Community Medicine residency, where I finished in 2015. So I've never even lived south of the Missouri River. I mean, so I'm a bona fide North Missouri all the way through. Coming back here in 2015 is always my plan to return, work for the hospital, serve the community that raised me realistically.
Yeah.
But then lots of opportunities came up, and I became the first Chief Medical Information Officer of Carroll County Memorial Hospital. We identified that role needed to be filled, and really it just working here and doing what I do has been everything I always wanted, even some things I didn't know I wanted.
Yeah.
And so it's been truly incredible, all the things that have happened to me in my 11 years here in the attending position.
Well, I've got to, I mean, again, you are a classic, which is always an awesome story where an individual, grows up, knows they want to come back and serve that community. And you guys know as in your roles how critical that is, right? Especially with as tough as it is for recruitment, especially physicians, executives, you name it. So I'm inclined to ask, I mean, what was it? Was it a grow your own program? Was it did you have family in medicine? I'm curious, what was that draw before you even left to say, you know what, I want to come back? Was it a medical experience you had?
Frankly, it was Dr. Pete Ross, who unfortunately just recently passed away. Dr. Ross practiced here for 50 plus years. He was a mentor to me then, really guided me along the pathway of family medicine, and took me under my wing when I was in high school, when I didn't even know yet that I wanted to be a doctor. When I left for college, that wasn't necessarily the plan. My family grew up farming. I have two older sisters. One of them is a physician. The other is not. She's a vice president of one of our local banks. But I always knew I kind of wanted to be at home. And a lot of that is the farming background, frankly.
Yeah.
That draws you back for all those reasons. But being able to come home and return, and frankly, not only I served under Dr. Ross as a non-actual medical student, as a pre-med student. I served under him as a medical student, and then I got to be his partner as well. And so those are the things that really, they all shaped me and ended up getting me back here to where I am.
Wow. Well, I can't wait to talk later in the conversation about just your experience with students, and we'll kind of get into our previous relationship. But tell us, I mean, you guys obviously CCMH, and either of you could take this question. I mean, you've had a long history as a nonprofit, non-tax supported hospital. I mean, why does that origin story still matter today? And give us some color around that.
Mm-hmm. Yeah. Well, I guess I'll say a couple things, then Andy can also jump in there. But it's interesting, our name, Carroll County Memorial Hospital. You think that we're a county-owned hospital and tax-supported. We are not. So it is just the name of our organization itself is a little bit, not quite accurate, as far as the public goes. But what I found since coming to Carrollton about 5 years ago, the people are very independent-minded. And so we are an independent hospital, and I can't see us, I'll say ever, maybe becoming part of a health system, because we look at around us, our service area, and we do what's best for the service area. And I think that's something that really helps us stick out, compared to some other hospitals that are in Missouri or elsewhere in the country. And again, I had some experience with that with my Mayo experience, but again, just the independence. And then what I found also is there's a lot of again, just pride and people moving back to the community, much like Dr. Horine had mentioned. We have people that came back and they started a local brewery and pizza place. They started a hotel and coffee shop. We've got people that actually came back and started a big cannabis factory here in town. So we've got a lot of people that have moved back, and they've created jobs. They wanted to raise their families in this community, and that's something very special. And I don't know if you can say that for a lot of communities, but it is most certainly the case here in Carrollton.
No doubt. And realistically, we're not that rural. We're rural. It's an hour and a half to the downtown Kansas City area. It's an hour and a half to Columbia, Missouri. Those are going to be our two biggest cities. So we're definitely rural, but there are plenty of other places that are more so. And Scott brings up a great point of the businesses that have started here and then expanded outside of Carrollton. We have a local lumber yard started by two locals who grew up here and stayed here. I think they have 6 locations across Missouri now, 5 or 6. So it's an interesting and very unique place where the people are fiercely independent, and the hospital really reflects that in our community. And so the idea of, we have watched, I remember when I was younger and watched some hospital systems begin to consolidate and people get purchased up. And I'm so grateful that we never did that. We went ahead and said, we're going to continue to stand on our own feet. We're going to function in that non-for-profit space because that's what our community needs.
Yep.
And we're going to continue to be that service beacon for the community in that nonprofit space.
Yeah. Well, I'm so excited at some point maybe to thread some of these conversations together with all these rural health leaders I've spoken to, because That is a common thread, right? The fiercely independent nature allows you to not be beholden to shareholders, to not be beholden to another entity, and be able to carry out your mission statement for your community, even when sometimes it may not make financial sense, right? I mean, when you need, when the community has a need and you deliver on it. So, I mean, when you guys think of rural healthcare right now, what's just one challenge people outside rural communities they often misunderstand? And I love this question, so I'd entertain either of you kind of taking that on.
For me, it goes to everyone there isn't a hospital system, I think, out there that probably isn't worried about their staffing scenario. However, again, unique challenges is what we used to call it the Walmart effect. Sometimes it's the Target effect, that there are people who won't come to a community because those places aren't here. We don't necessarily want those here. We want to support our local businesses. We don't need the international conglomerate place here in our community. But those are significant challenges to us, because not only do we have to be competitive from a salary standpoint, we also have to convince people that our geography is not that bad. I promise it's not that far to go to Walmart or Target if that's where you need to go.
Right. Right.
Yeah. And I would add to that, again, hospitals across the country, I mean, they have to meet the, Medicare, Medicaid standards, and some are Joint Commission accredited. So there's standards that have to be met no matter how large or small you are. So, and again, for a smaller place, some of those things don't, make the greatest sense, but we have to do it anyway. So for instance, a lot of times when people think about hospitals, they think about like heads and beds. They say, well, how many beds do you have and how many? So like, we're licensed for 25 beds, but I think since I've been here, the most we've ever had at one time is 15. So, and again, I think most people think more of inpatient as opposed to outpatient, and like 90% of our revenue is actually outpatient revenue. So that's another, kind of a thing that, is hard to register, I think, with just the general public. And again, we look at some of our other numbers. I mean, on average, we have about 12 ER patients a day. So again, we have to staff our emergency room to take care of whatever comes in. And again, the numbers and the volumes are, tend to be a lot lower than, of course, the metro hospitals where you have to maybe wait for 8 hours to be seen. And that, of course, isn't the case here at all.
Yeah. Well, you talk about all of the confines and basically the regulatory burden, right? The things that you guys have to abide by as a small hospital, just like a large hospital would. But I mean, obviously you have some benefit, right? Being a critical access hospital. Tell us a little bit about some of the benefits outside of just the independence, but of your structure that helps you weather, maybe some financial headwinds a little bit better than some of your smaller peers.
Mm-hmm. Yeah. Well, I think being small, we're like a speedboat. I mean, we can turn on a dime, and that isn't necessarily the case with, a lot of the larger, hospitals or systems. They have a lot of people, a lot of bureaucracy, maybe levels of management that have to be spoken to and things like that. And in our situation, I mean, we have a medical staff meeting and we make decisions there, and boom, it's over with. So we're able to do things a lot quicker, I think. So I think that's one of the benefits to us, certainly. And there are some payment things that help us out. Yep. Being a critical access hospital, we have cost-based reimbursement, which is in our case better because of our lower volume. As opposed to the prospective payment system hospitals, and again some of the larger hospitals that deal with getting reimbursed from the government on a different level. So that helps us out. We're also a rural health clinic, and so there's some spiffs that go along with that as well. So we do try to take advantage of some of these special programs that are set up for rural places such as ourselves, and I think that has been very helpful for us.
Yeah.
And certainly too, but the lower median income, we had a lot when I first started of underinsured. Thankfully, that's a little better than it used to be, but a very large Medicare population and Medicaid population, people who are on those programs. Sometimes you call a physician's office or a hospital to want an appointment, and of course that has to be evaluated. Sometimes they just don't even take that information. It just doesn't. They don't even take those insurance carriers. Right. And we do, with being a critical access hospital, being a rural healthcare clinic, we're able to take those and be able to continue to make the bottom line work itself out so we can take care of the patients as well.
Yeah. Well, you talk about, which is awesome to hear, your uninsured population dwindling. How do you guys, what is your outlook and this may be a legislative question, right? But Andy, I know you've spent some time in DC with all the changes to Medicaid and redetermination and so forth. Do you expect that that population to remain the same? Do you expect that to be a headwind? Just kind of give me your thoughts around that.
It's going to be a double-edged sword. There's absolutely no doubt about it. With the changes that are coming out of the One Big Beautiful Bill and the Rural Health Transformation Program, there's plenty of positives that we should focus on. But at the same time, we're also going to be reducing some of the payments under some of those legacy systems.
Right.
And we've got to figure out if that's going to work itself out. And it's going to take time. There's a lot of trepidation, especially in a small hospital, of how do we make sure that we're using those appropriately. So when we see that balance come out, I really hope we don't see that there's less money flowing to a rural hospital, less money flowing to a rural facility. That's going to take a lot of diligent work on the part of leadership to everyone in the country, across every state and every county. However, all the people are setting up what happens with rural health transformation funds. We're going to have to be extraordinarily diligent to make sure those taxpayer dollars end up benefiting the taxpayers who gave them to the government to get back to us. It's going to continue to be a moving target that we have to stay very limber on, as Scott alluded to, and make sure we're adapting to every situation as it shows itself.
Yeah. Well, I'm excited to see what and how hospitals and we should know more, in the coming months, right, as to the Rural Health Transformation Act, how it's going to roll out, who's going to be responsible, the different hubs, et cetera. We've talked about that in some other sessions. But it is targeted for innovation, right? And we'll call that a broad bucket. There's a lot of things that go into that, but I imagine, leaders like yourself are going to be forced to take a hard look and say, where do we need the funds and how can we look to the next 10 years versus using, funds that might be doled out just as a crutch, right? And so I love the way you guys are approaching it. I mean, for the last, call it 4 years, CCMH has been named a top 100 critical access hospital by Chartis Center for Rural Health, and in I believe 2 of those years was named a top 20 critical access hospital by the National Rural Health Association. So kudos to you guys. I mean, how proud are you of these designations, and what are the recognitions, or these recognitions, I guess, signal to your community and peers?
Yeah, well, again, the Chartis has been doing this for like the last 16 years, so for us to be named 4 years in a row, and as far as I know, I don't think any other rural Missouri critical access hospital has been able to achieve that. So I think that we're really kind of at the forefront as it relates to that. And I don't believe any other Missouri critical access hospital has been named to the top 20. So the top 100 gets you to the top 8% in the country. There's roughly 1,300 critical access hospitals in the country. And the top 20 gets you to the top like 1.5%. So I think it says a lot to us. Is like we really know what we're doing, and there's a reason for patients to come here and not bypass us. And I think that I think some of the other maybe hospitals around us, they look to us and say, wow, I'd like to achieve that. So maybe we're helping them strive to be better institutions as well. And so I love being in the catbird seat. I mean, it's great. I know Dr. Horine and I and our chief nursing officer were able to go to Kansas City last September and pick up our award, and that, I mean, we felt really good about that. And it's kind of like an elixir. We want to have it happen again. So
shot in the arm.
That's right. So we'll find out in a couple of months here if we can make it 3 of the last 4 years. And so that would be a fitting way for me to leave, I guess. So I'm looking forward to that.
Leave a lasting legacy. Well, obviously it's a huge accomplishment in both regards. I mean, tell us, this podcast is really intended, our audience is other rural health leaders. So, if you don't mind, obviously a lot goes into both of those designations, but give me a couple highlights that attribute to the success you've been able to have with some of these recognitions, that other leaders might take as takeaways from your success.
Mm-hmm. Yeah. Well, I think a lot of it starts with culture. So you have to have an environment where, people, they just really want to achieve and they want to exceed customers' expectations. So the patients come in here and we just want to, take care of them, even the things that they didn't think that they needed. We want to make sure that we are covering that. And again, Dr. Horine is a provider, is a physician here. He has a chance to do that each and every day, with patients. And I've seen him in operation, and he's amazing. And so that's the kind of history that we want to share with the patients as they come in and leave our organization. And of course, word of mouth is the best kind of advertising there can be. And so we want people to go out and talk to their neighbors and their family members and just say, I had a great experience at the hospital in Carrollton. And I know when I do orientation every couple times a month for our new employees, I ask them, well, why did you choose us? And a lot of times they say, well, I've talked to other people that have worked here, or my family has been a patient here, and I really liked the care that was shared with them, and I want to be part of it. And so it's like, because again, they could have gone and got a job anywhere, but they've chosen to come and work for us. So I just think that just is so special, and our word is getting out there, and I couldn't be happier.
Yeah.
Every organization will talk about the culture. I'll tell you, I obviously am not only, in the community culture, but the hospital culture here. But again, we talked about independence. We talked about the uniqueness. For me, I am an employed physician. There are potentially physicians who came up in an era where that would have been unheard of for a physician to be employed by a hospital. Now it's more or less the standard, or some sort of group type practice. But I still have, because of all of the things we've talked about to this point, I still have a lot of independence as a physician. We all have boxes to check. We all have regulations we have to apply to. But then I am allowed to do what's best for that patient in that moment. Those are the things I think that will set CCMH apart and continue to keep us in that. I know we've been doing that a long time. People are just now starting to notice, and it's because the patient is at the center. The patient is the one that we're focused on in any given moment, serving them then, serving them in the future, and making sure we keep them healthy. Like, anybody can find an illness. That's easy. It's finding health that's the problem.
Right. Well, you guys have done, just Scott, from your comments, culture, perception, that's something you got to control and make a priority. And I'm sure you guys have, just given the sentiments and the comments you've shared. And same with you, Dr. I think it's extraordinary to hear what is going on, right, in our own community hospital. What can we do really well, and finding partnerships where it makes sense. But the independence is key, because you get to decide, and obviously you've made the right decisions, right? You've reached some of these awards that are coveted, and so kudos to you guys. What's something special you think the hospital is doing exceptionally well right now that you wish more people knew about? And that could be a long list, but
sure. For me, and it's probably partially because of my role, we're staying on the absolute forefront of technology. We're staying on the cutting edge of all of the latest things. We do not allow those to just trickle down, and we'll get to it once the big guys have got it figured out. We're figuring it out, and it's trickling up to the big guys in a lot of some of these technology things. We've been a most wired hospital many times in the past as well. And that's because everyone understands that technology, and of course, AI technology now, we're spearheading all of those things. We're making sure that we have an influence in its development, because it's coming whether you want it or not. So let's make sure that we're actually being the ones out there helping to show what it can be and how we can make it better.
Yeah.
Mm-hmm. Yeah, I would agree with that. As a matter of fact, we just obtained a couple of new ultrasound machines that our ultrasound sonographers are just totally in love with. And, we think that we're, cutting edge, above, kind of some of our surrounding hospitals. And by having that kind of technology, they've been able to essentially, in a couple of cases, help patients avoid a surgery. So that's really amazing when you're able to actually not have to have somebody go under the knife, because we're able to use some ultrasound technology to say, hey, you got a problem, but it's, you don't need that kind of a intervention. So we're really, glad to hear that. I think, Dr. Horine was talking about technology, but, as it relates to just ease of access, I will say. So we have the ability in our primary care clinic to get patients in most cases the same day if they need to be seen. And certainly we have a statistic known as the third next available appointment. And that's it's probably averaging around 3 days, so in a lot of the bigger cities, it's like 29 days for primary care, and actually kind of the 50th percentile for rural medicine is about 8 days. So we're able to get patients in a lot faster. And also we have visiting specialists here that you're able to get to see them a lot sooner than if you tried to get to see them in Kansas City or Columbia or something like that. So I like to call it that we're the quicker fixer-upper. So I don't know if some of my colleagues don't like that because it's too close to some paper towel company, but we're really happy to, I like to call it, we're the quicker fixer-upper.
Wow, that's beautiful. I mean, especially when you talk about, from a serious note, caring for your community and that being part of your mission statement, being able to be working expeditiously to get folks in and be seen. I mean, that's extremely commendable. I mean, Scott, you came to CCMH after, as you described, decades in rural health with the Mayo Clinic health system and critical access settings. I mean, tell the audience what lessons, I guess, would from that experience have translated best to Carrollton. And I ask that question because many healthcare administrators have varying backgrounds, but you've spent yours predominantly in rural health, and a lot's changed, right? So,
Oh, yeah.
Tell us what's translated best.
Yeah. Well, Mayo's value statement was the needs of the patient come first. And I've always remembered that. Everybody in Mayo remembers this. And I've tried to bring that to, this location here in Carrollton, and they already had it, quite frankly. But so definitely the needs of the patient come first. The other thing I think from, my Mayo experience was that, again, very heavily regulated. They were Joint Commission, kind of surveyed. And so I have a lot of like a standards and ethics and morals background. And so I definitely wanted to bring all those things with me to my next organization. So I had a boss in Mayo that said, Mayo is more Catholic than the Pope, which basically meant that they were, if there was a guideline or a requirement, they were going to get a 12 out of 10 on it. And so I've tried to take that with me as well. And just saying, we're gonna be super on top of things, and we're doing things the right way.
Wow. Well, I mean, when you stepped into the role 5 years ago, you're forced to take your experience, come to this new organization, and then take account, right? For what do I want some of my priorities to be after you get your feet wet, have an understanding of the culture, what's going on, the service lines. What was when you stepped into the role, kind of your first priority? What did you identify? Hey, I want/need to tackle this thing right now.
Yeah. Well, my very first thing, probably in the first 3 months, is I wanted to talk to as many people as I could. And I did. I talked to all of our physicians, our nurse practitioners, our hospital board members, foundation board members. I wanted to talk to the police department. I wanted to talk to the librarian. I wanted to talk to the Chamber of Commerce people, the public health person, the ambulance folks. I wanted to kind of take it all in and just see kind of what are the issues that we needed to address in the community. And and again, there's a thought that hospitals or clinics on their own only take care of about 20% of a person's health. So like 80% of a person's health happens outside of our campus. So it might be housing situations, or they got food insecurity, or these kinds of things. So I was as many other hospitals across the country we're trying to really incorporate that into how we take care of patients. And so it's not just Dr. Horine giving them a prescription to go get some pills, which they might or might not do, or might not be able to afford. And so these are the things that we really wanted to kind of dive into and see if we could kind of work on some of these kind of non-traditional things in healthcare. And I think that it's a long haul because, again, it's we're just taking baby steps here, but I think we're definitely going in the right direction, and I think that we're all going to be better for it.
Yeah, well, it's certainly, I love that you're taking a holistic approach, right? I mean, it's the community, the hospital is reactive and does a great job, right, of being reactive when you need to be, but there are a lot of other factors that play into before they a patient steps in your front door. I mean, tell me a little bit about, so your first priority was really taking account of what the community needs, shoring up relationships. For other health leaders listening, do you make that a systematic approach, right? The relationships with your employees, the community, other stakeholders, other business leaders are supremely important, as you've alluded to. Why did you make it a priority? Was it systematic? And what does it do for you having those relationships? How do you think that benefits versus it being less of a priority, right?
Yeah. No, I would definitely say it was a priority, and I think relationships are just so important in certainly in our geography. And I'm able to pick up the phone and call somebody and say, "Hey, I got this idea. This is something that you can work with us on." And we just have a lot of, I guess, folks in the community there. They think similarly, and they're not afraid to get their hands dirty and pitch in and get some things accomplished. So we've got a few, like for instance, we have a couple of task forces. One that deals with mental health and substance abuse, and we've been able to make some headway with suicide reduction education, in our area. And we're also working to try to get some of the opioids off the streets, and and deal with those kinds of things, and make, for instance, we have a particular a bag that we've worked with the pharmacies here in town, so patients can secure their narcotics or other things in there, so their family members can't essentially take them from them. And then if they're done with them, they don't need them anymore. We have a way of disposing of them safely, and again, kind of getting them out of harm's reach, you might say. So we just have any number of different things that we've worked on, and that's just one of them. But I think that the community is willing, like I say, to dive in and participate, and I find that very refreshing.
Yeah. Well, the participation with the community is huge. I mean, kind of building on that, I mean, what's your philosophy on, you're just talking being rural, right? Your philosophy on culture in a small hospital where everyone knows everyone, right? How do you set the tone? When is it a benefit, and where do you have to be cognizant?
Yeah. Well, my predecessor had done birthday cards for everybody. So he signed their name and had sent off. So I thought, that's nice. I'd like to take it a little bit further. So what I did was we have roughly 260 people in our building. And so my goal was to try to interact with each of them at least once a year on their birthday, and probably a lot more than that. So I write them more of a kind of a handwritten note, try to really have a connection with them. And I slip them a lottery ticket at the same time, so they can scratch off. And so, but never enough so they could retire. So if they want. But that was just, one thing that I've done. And I like to do, they call management by walking around. So I never want to just get stuck in my office, because I always want to understand what's really happening. I ask people, like, well, what's getting in the way of your role today?
Right.
And are we winning? And these kinds of things. And so I like to hear that. And then of course we work to address the birds in the saddle that people might have. So again, I just like to be out there and not confined to my office.
Yeah. Well, I mean,
for all the healthcare leaders that are out there and are hearing that, I've been here, like I said, 11 plus years. I've been blessed to have exactly 2 chief executive officers, and both of them, I can say, spent the time on the pavement, pounding the pavement, being there, knowing the employee, knowing their name, knowing where they're going to be, how's their day going, what's the feel, what's the vibe, more than what they're saying, how are they saying it? You want to ask, how do you improve the culture inside your organization? Any business can benefit from that advice from Scott right there.
wow. Well, I mean, that's just great advice, and I'm glad you again, it's something you guys have strategically, you made a priority, right? Then we work with a lot of hospitals, and I'm always curious when I walk by, if I have the opportunity to walk by either a CEO or an executive's office, the amount of times I'll see a CEO sitting right there in their chair is next to none, right? Because hopefully they're out doing exactly what you've talked about. So I think that's great. I want to kind of harken back and shift gears a little bit. You guys talked, Dr. Horine, especially about the investment you guys have made in technology. I know we'll get into that a little bit here in a minute, but if you and Scott could talk about, I mean, with 250 plus employees, a rural hospital budget that has to stretch, technology you have to invest in. I mean, this is a question I always ask. And I mean, how do you decide where to invest resources for another leader listening?
We've had wonderful support from our board over the years when we decide where we have to do things, and setting it up in a strategic manner. I mean, going back, even a couple of decades, we can understand, when is our MRI machine going to begin to get to the 3/4 point of its life expectancy, so that we can go ahead and switch that out, and so that those budgetary items can be managed and spread over the course of time. And that is, especially as we've gone through leadership changes, has been something that stayed at the bedrock of what we're doing. And so then we can say, okay, we have our patients taken care of, we have our employees taken care of. Now, what are they going to need so that we can continue to do A and B? And that's how I see our approach that we've done, and prioritizing, making sure we do have the imaging, making sure that we have, frankly, a good working internet, and that our EHR is top notch, and that those are the things that are going to be interacted with on a daily basis from an employee standpoint. It probably came up in people walking around, hearing, we started to have connectivity issues in one part. Well, all of a sudden that means that's got to get some attention because there must be some bug. We got that fixed. And again, being able to be agile and being able to do that without having to, wait for 4 layers of bureaucracy is hugely advantageous.
Right. Right. Well, I'm going to get to your role as the first chief medical information officer and some of the things you guys are doing with technology. But let's start with just the teaching hospital identity, right? I mean, you guys and either of you can jump in here. I mean, you've described CCMH as the most teaching, non-teaching hospital around, right? I mean, what do you mean by that? And what is education and training? Why is it such a strategic focus for you? And I say all this full well knowing my wife, had the opportunity to work with you, Dr. Horine, when she was going through physician assistant school. So, and had a great experience, of course. And so tell me, I mean, give me kind of the benefits. Why is it a strategic focus? And what's it done for the hospital?
Shout out Lauren Hurley, who was not her last name when she was here with me, but when for me, and it is, there's mostly going to be healthcare leaders and any physicians who are on here. Students they're not always the easiest thing to have around. Needing to teach them, it doesn't always make our lives easier. And there's plenty of old adage about that. For me, I look at it twofold. Number one, if I'm doing a great job, I owe a duty to the future of healthcare to pass that information along. And then for the students then to learn not only the science, not only the medicine, not only the click boxes of everything, but how to interact with a patient and get them to listen to what I'm saying. You don't always win, and you're never going to be 100%, but sometimes the way that you talk to a patient about the fact that they really need to control everybody knows they need to control their blood sugar, but why is it important? What am I looking at on your lab numbers that tell me what's going to potentially happen to you in the future, and understanding that the decision we make today are 10 years down the road. Getting that information, learning how to have that interaction with a patient, you're not going to find it in a textbook. It doesn't exist. It's going to come when a student is with an attending physician who can learn from them how to interact and build the relationship with the patient, where that they do understand the importance of what you're saying. And then secondarily, we've already talked about, every organization on this planet is worried about staffing. Whether it's a nursing student, whether it's a nurse's aide student from our high school, whether it's our health occupations class here at our local career center, whether it is a physician assistant school, a nurse practitioner for an RN who's already on staff with us here and now needs clinical hours, or our med students that are coming from the UMKC campus now. Those people coming here, having a good working experience, beginning to get involved with the community if they are from outside of here, that's a 4 to 12 week window where I get to interview them. It is literally a minute by minute every day. Do I want to work with this person for the next 15 to 20 years of my career? And then I'm hoping I can show them how great Carrollton and how great Carroll County Memorial Hospital is, whereas they may never even know where we are, who we are. And so getting those people and having that opportunity, it fulfills my duty to continue the education that I got from Dr. Ross. Yeah. But then also it gives me a chance to go, who do I want to try to recruit? And Lauren she just wouldn't listen to me. She had a boyfriend at the time. She didn't know what they were going to be doing with their lives. So I tried, I gave it my best effort, but she moved on. And so I'm very happy for both of you.
Well, I can say definitively that what you're sharing is indicative of the response she would give if she was sitting right here on this call. I mean, just the I don't know if we want to call it bedside manner, but I mean, just the way in which, again, the science is important, the clinical expertise is important, which, a student's going to learn throughout their time being out in the field outside of the school setting. But, it's kind of a recruiting tool, right? If you're doing that and no, others may not be making it such a priority with their students. Again, you're interviewing them, but they're going, maybe this is a place for me to land, right? I mean, maybe this is the type of environment I want to be in, which I think, we hear about the landscape changing from physicians coming out of school and maybe not being that attraction to the large system that there's been for a variety of reasons, right? And so you talk about recruiting tools. You can expound on that if you want, but I would imagine that is huge. Again, that 4 to 6 weeks, trying to get them inundated, not just with your organization and how it might be to work there, but again, the Carrollton community. It's a full package.
Well, absolutely. And I spent time on those rotations. I slept in call rooms that I wouldn't, it was just really not ideal. And frankly, with a lot of our leadership here, and I'm going to toss it to Scott about the Student Learning Center, because if I was a student and I walked into what we've got to offer them right now, it would have been, an extremely attractive thing. And I would go, how are these people pulling this off? And frankly, it was Scott's leadership that got us that.
Well, I'll even preface that for you, Scott. I mean, the new Student Learning Center, it sounds like a major investment from what I've read. I mean, student housing plus a learning lab. Go off that riff. I mean, what impact are you seeing or hoping to see from it after making that investment?
Yeah. Well, actually, it was a building across the street from the hospital. It used to be an old optometry clinic. And so it was just sitting there. Nothing was really happening much with it. And we were debating over time, well, should we turn it into a parking lot or what should we do with it? And then somewhere along the line, Dr. Horine and Dr. Rawls from our staff have had more interaction with UMKC, Dr. Mike Wacker there and some other some physicians. And so we just said, hey, how about if we, we're seeing your students here, your longitudinal clerkship students, which are second year med students that are here for 3 months at a time. And it's like, well, how about if we fixed up a nice building for them and we had some educational space and all that. And they were able to provide us with some grant funding, which we really made use of. And so we ended up redoing this building to essentially be like a 3 apartment unit building on one side. And on the other side, it's kind of an educational space that has our real fancy Anatomage table, $100,000 Anatomage table. Dr. Horine can describe that in a moment here. But and then we're even using it for our high school students. So Mandy Plackey is actually the instructor at the Health Occupations program here in town, and she's also one of our surgery nurses. And I remember her saying, hey, what's on her wish list? And her wish list was this Anatomage table. And I said, well, we'll look into it, see if we can get it here. And sure enough, with the help of UMKC, we're able to do that. And I think the nearest one to us is maybe in Sedalia at the State Fair Community College, as well as in Kansas City. So we're able to make use of that piece of technology in our teaching, the medical students teaching. And we're thinking it's really getting the students in high school really interested in careers in healthcare. I'll let Dr. Horine take it from here.
Yeah, I mean, very, very, interesting technology. It's about 7 foot long and about 3 foot deep for those who are thinking about it. And it lays flat and looks like an anatomy table that I would have experienced when I was in med school, except it is a 3-dimensional manipulable projection of a cadaver specimen. So it does do 2 things. Number one, everyone should remember healthcare leaders, anatomy is power. So when you're talking about all these things and you're educating students, I go back to those fundamentals because that's the important part, because then they can explain it to the patient. But number 2, we're getting a lot of buzz because it's a really neat, really interesting thing. And I hope it builds more interest in the health occupations class and the Health Occupations Student Association, or HOSA. They have competitions for high school students and frankly, upper level collegiate students. They have competitions for these all across the country. And if it's another thing at the high school level, again, we're going from the high school level all the way through, medical students. We're trying to get our hooks in them. We're trying to get them interested in STEM. We're trying to get them interested in healthcare. We've provided some funds for some of our local schools for STEM education. That is the center of, if we're going to say we need more staff, well, okay, train them. If you need more staff in your organization, figure out a way to train them, figure out a way to get those students interested, those that are embrace them, educate them, and really brew them up to become the next CMIO of your hospital. That's what you should be doing.
Yeah. Well, it's kind of crazy. I mean, we're having this kind. I mean, at Gallagher, right? We consult with healthcare companies around their comp planning, strategic planning, how they should structure, physician pay and rank and file, and even on the benefit side, how to structure an attractive program to attract, retain, do all the things you need to do. But at some point, as a rural healthcare facility, you got to invest way beyond your own employees to even, to your point, have a shot of them coming back. Because we know, and just from what I've heard, not being in healthcare, not being an administrator, a clinician, that's your biggest bucket to pull from. And so you guys knocking it out of the park by getting them that early. I hope it's started to pay off. I know some of this is new, but I do want to touch on, I mean, obviously that was a strategic effort, but tell us about, kind of coming back a little bit, the partnership with UMKC. Tell us how it came about, and was there a problem you were trying to solve? I mean, again, that partnership led to being able to provide this Anatomage table and increase your ability for education and inspiration for some of these students. But tell me how the partnership came about, and then some of the benefits that have flowed therein.
It was kind of a twofold. Dr. Pam Rawls, who's on our staff and was mentioned earlier, she is a UMKC graduate. That's where she went. It's not where I went, but one of my, I guess not my residency classmates, one of my residency juniors, he was sort of in the class behind me, is on staff at the St. Joseph UMKC Medical School campus. And they reached out to us. And I think it's because of some of the things we talked about, of some of our reputation as far as education. They said, hey, we're starting this new thing, long-term longitudinal integrated clerkship, which is different than I did med school. I did it in 4-week chunks, where you were every 4 weeks, you're going to a different place. What they're doing is they're investing in getting people more interested in rural medicine. And so they're looking for small, independent, rural hospitals specifically, and saying, we're going to send you a student for 12 weeks. And we want them to go from the family medicine clinic. We want them to be working in the emergency department, at our wound care clinic. They want them to spend a day over with the surgeon, and then they come back to the family medicine clinic. And it has happened just like they told us that day. That student starts to see patient Smith was seen, has a bad gallbladder, got referred to surgery. They saw him in the surgery clinic. They then went to the OR with him, and then saw him and followed, and they see the full picture of what a rural hospital, in all hospitals, but how it works in our microcosm. And it's the best type of education that a med student can get. I can tell you, about the time I was comfortable and I knew what a rotation needed from me, I'm off to the next one. Well, yeah, they may be bouncing around from day to day, but they're seeing the same faces. Most importantly, we're seeing the same nurses, and they understand that that's where their bread is buttered, number one. But then number two, that they start to see how to deal with that whole patient healthcare, not just the slice of working in a general surgery office for 4 weeks, not just working with Dr. Horine in a primary care clinic for 4 weeks. Full disclosure, I was skeptical. It's not the way I was trained. But I kept an open mind and said, yeah, let's give it a try. They want to send us more students. They want to send us 2 students per 12-week block. They love it out here. We love having them. So far, it's been a huge win for everybody.
Yeah. Well, I mean, correct me, I mean, is this an innovative program with UMKC? I mean, is this going on around the country? Because again, I can see the benefit just as you describe it, right? Going back to my wife, that's how going through PAC, and we're talking about mid-levels, physicians, et cetera, but that's how it was. It was sliced and diced, and now you have an opportunity to bring a student through rural health and immerse them in that total patient experience, understand, what it looks like to partner, and when it makes sense, when it doesn't, when we invest in our community, right, to be able to give the care that we can locally at a very, very high level. I mean, so when students rotate through CCMH, what do they hope to leave with professionally and personally? And if you want to touch on UMKC again, I'd be curious if it is an innovative program, or if it's going on other places.
I do believe it is. There's several of these sort of long-term integrated longitude. I keep saying long-term. There are several of these longitudinal integrated clerkships that are going on It's not completely unique, I think, but I love the way UMKC is approaching it because they're trying to get it to the rural hospitals.
Right.
So of course that speaks to my heart. I'm not sure I know what students would want. I can tell you what I want. I want them to come in. I want them to feel our culture. I want them to connect with these patients. I want them, and it's happened already multiple times. They didn't quite get one of them finished. They had to leave and head to the next rotation. Please call me, update me about patient Smith. Please, I'm sure that's what I want. I want them to learn the connection that I feel with all of my patients. And leave here and go, that's what I want to go search for. Whatever specialty they want to find, I want them to remember their time here and remember that that patient was at the center and the difference we made in their lives and the impact they had with them that day. That's what I want them to leave here with.
Yeah. Yeah. Well, I mean, how does this, I mean, again, we're kind of coming full circle to the strategy at the hospital. I mean, how does this education focus connect to all the things we've alluded to, recruitment, retention, and current healthcare workforce shortages, right? You guys are being intentional. Have you seen the return on investment? Is it a slow burn? Kind of what's your takeaway from starting this program from that standpoint?
Well, I can mention, and again, we see students from all disciplines. So, for instance, our most recent hire as a physical therapist did come from Mizzou, and it came from doing exactly what Dr. Horine was talking about. So, physical therapists are very hard to find in rural Missouri, rural America, and the fact that we have an awesome rehab program, probably one of the best in the state. I will lay odds on that. And they got this particular individual got to experience that and said, "Hey, this is a special place. I want to be part of this." And sure enough, and again, like Dr. Horine mentioned, we get to try before we buy, in some of these situations.
Right.
And so it's like we want him, and we were able to make it work. And so he's here in our community, and he's doing stuff with the YMCA even. I mean, so he's all over the place. So we really like people with his kind of energy. And the type of provider that patients want to see. And so I think that was just a recent example of a nice win that we have as a result of doing this education that we're really so high on anyway.
Yeah. Well, I mean, let's parlay that. I mean, the energy, tenacity, Dr. Horine that you've had, which I have to assume is what's gotten you to jump either head first, feet first, whatever, into technology, AI advancements, and just over technology leadership, right, in your role as the clinical information medical officer. But I mean, in January, if I'm not mistaken, you were one of about 20 rural health physicians invited to Washington, D.C. To participate in the White House roundtable focused on rural healthcare challenges and policy solutions, where I believe the president and others spoke. So, I mean, tell us about that experience and those conversations, and then I want to get into your role as or Chief Medical Information Officer.
Yeah. So, first of all, if you had told me ever that I would get a call on a Monday and be at the White House on a Friday, I would have laughed you out of the room. Maybe tried to see if you needed some mental health care, because it truly was an honor. And it is because of some of the things that we've worked on over the years and being at the forefront of technology. When I came here in 2015 with the then Cerner, now Oracle Health Corporation, our EHR vendor. We were able to, our EHR partner, which is a much more appropriate description of the relationship. I was able to get that opportunity and participate and talk to people who genuinely wanted to know what it's like, kind of like this podcast. They really want to know, what is it like on the actual front lines when we're talking about changes in Medicare payment, changes in Medicaid payment, the rural health transformation, all these things. What does it look like to you as a person who spends your day and your night on the front lines of medicine in rural America? What does it look like? And even just getting to meet and interact with other rural physicians that were there, and I guess the wrong term, but it's allied health. There were nursing representatives there. There were people representative from EMS. They're actually also from Missouri that I know because of some of my EMS work things as well. All of those people being in that one room and getting to tell their story and making sure that the folks who are making decisions on our behalf really understand what it is that we're doing and where we're going to put this to work at. Truly an honor to even be invited, and big thank you to everybody who helped make that happen for me.
Yeah, well, that's awesome, and I hope it was, I hope your voice was heard. We talk a lot about lobbying budgets, legislative affairs, and just how much is out there to try and capture, right, the attention of our legislators to make them aware of the problems and the high priorities within, especially in rural health. And so it's awesome. We got to have a representative from the state, and I'm sure it went over really, really, really well. So again, kind of coming back, you're the hospital's first clinical medical information officer. Tell us about that role. Why was it important to create? And what are you really focused on in that segment outside of all the other things you do, right? And the other hats you wear, just being a physician, et cetera.
When I was approached to do it, becoming the first one, that's obviously relatively common across everything. Yeah. Every role is going to be different. Every CMIO is going to do things a little bit differently, but it hinges on the center pivot of the electronic health record. When electronic health records, really became popular in the early 2000s, and then essentially were forced upon everyone to have one as the late 2000s came about. CCMH was a leader then, long before my time, adopting in 2009 into 2010. And unlike many places, and I think this is a strategic strength, we've never changed. We've been on the same EHR partner since that time. And so we haven't had to go through those transitions and all the costs that are associated with that. As when I came in 2015, we didn't have sort of the physician at that point. It would have been, and still is called, a physician champion. The physicians were sort of just like, yep, we're all going to do it. But there wasn't the person that sort of stuck out. Probably because I'm the youngest, I guess. They just said, hey, we want you to do more. And it became doing more and more. And it became our partnership with what was at that time the Cerner organization, which was, of course, based out of Kansas City. So just right down the road from us. We ended up being very innovative in being a small hospital on an EHR of that size. And that it continued to snowball. And so then it said, we need to put some teeth to the work you're doing, essentially, and sort of put that title on me. And truly, that was an honor to even be asked. And I've really embraced that role. And again, for healthcare leaders, if you just have that physician champion, which I hope everyone does, but then if you don't have that clear CMIO, and I'd say most do, but if you don't, that person I think is crucial, because I don't want Scott to fire me. Of course, they're crucial. I need that. That person's crucial for an organization to be the physician pivot around the single item that touches every aspect of patient care, every aspect of their employees' work, somewhere flows through that electronic health record and then the entire information technology systems within your organization. You need that person, those physicians that have that big voice. I guess I am the big voice person. Scott's he's probably nodding at this point. Yeah, I'm the big voice person. I'm going to say, no, we don't work around it. We're going to figure out how to fix it. Let's tell me what the issue is. Right. Tell me where your pain point is. And then how do we innovate that? And then again, continuing to keep us on the spear point of that innovation with some of our AI adoptions that started 2+ years ago at this point. Then we're really seeing that those technologies can make our lives better as physicians, and then make our patients' lives better as well. If I'm getting a 2-for-1 on that, why in the world wouldn't I be all in on something? Every new technology should come with caution, and we're taking those cautions. Those guardrails are up. We're learning things as we go. But that's what I've done as the role in a small hospital. How do I make sure that we are staying one step ahead? As soon as you're behind, now you've really got a problem, because you've got to do a massive uplift. I want to be out in front. I want to be doing those things, innovating, showing our EHR partner how this does affect it. Did it do what they thought? It didn't do what they thought. How can we fix it? I want to give them that feedback. That's how it's a partnership. That's how it works. And every EHR vendor should be working with their organization that way.
Yeah. Well, I love how coordinated you are. I mean, and even just identifying the fact that, hey, we've got a lot of physicians, a lot of stakeholders. Why not have a physician represent us at the organization? Again, to our views, where do we need investment? And again, going back to just being independent, you being able to be nimble and make those decisions make investments a lot more quickly than say a larger system with, I think the word we use, more bureaucracy, right? So I mean, AI, let's talk about that a little. I mean, it's suddenly everywhere in healthcare, right? So from your perspective, where do you see the most promising uses of it in the rural hospital, rural healthcare setting so far?
It's suddenly everywhere. And if you're listening to this thinking, I really haven't bit into that yet, you have. You just don't know it. Because I promise, it's literally in every search, every time you've done anything, I want to find a restaurant. Trust me, it's out there. In healthcare, here is where I had this moment a couple of times. I've walked in, I've turned on my AI assistant for note writing, right? That's the primary objective right now, but there's more coming. I turn it on, and then I'm completely and totally focused on the patient as I was prior. And that thing is just doing its thing in the background. And what was I doing previously? I was listening to the patient. I was taking care of what they did. I was maybe jotting down a note. Maybe I was typing. And then I come back to my office, whether it's right after that patient, whether that is at the end of the day, whether that is 9:00 at night after people have put their kids to bed and soccer games are over. And then they're doing their pajama time. And they're getting that note done. And they are sitting with a microphone, or they're typing, or they're whatever it is, and they are recapturing what the work they've already done. Guess what? I go in, I see the patient, I talk to the patient, we talk about their 5 problems, what we're making changes on. I do what they taught us in med school, which is make sure you do teach back, make sure the patient understood what you're saying, and that way they understand, and you review all their medications. Within 1 minute, I come back to my computer and my note is done. I'm not having to do the work twice. When you are sitting and educating a patient about the risks and benefits of the medication you're starting, you then have to come back, sit down at your computer, and even if you have a hotkey for it, I know everybody's got shortcuts, I have them, but it's already done. It captures the fact that you spent the time with that patient to educate that patient, to explain to them their diabetes disease process, to talk about a cancer diagnosis, to explain why we do a preventative screening for something. Instead of having to spend, if it took you 1.5 minutes to explain the benefits of mammography to a patient and 30 seconds to dictate it, I just took your 30 seconds away, because the AI is going to capture that. And it's already happening. It's going to capture that you ordered a mammogram for that patient. It's going to capture that you refilled their lisinopril for their blood pressure. All of those are going to be teed up. They're going to be waiting for you to do a final signature as a physician to review, and do a final signature as a clinician. The incredible power associated with embracing this technology is huge. Now, giant asterisk. And it applies to anyone using any type of voice-to-text dictation. If you are still using a live human to listen and do a dictation for your notes, or if you're hunt and chicken pecking typing, as a clinician, when you hit sign, you are endorsing what is there, and it is solely your responsibility.
Right.
Now, I'm off the soapbox for a minute, but that message cannot be missed. It's the same. Just because it's AI and it's new and it has some things that we need to have safety and guardrails up for, which we do, but it's still ultimately the responsibility of the clinician to make sure that AI has not hallucinated something. It is a fact, just like when we were doing old school dictaphones and then had to sign off a note that came to us, you were responsible to read that note. It's the same thing. There's no difference. It's just a different medium now.
Yeah. Well, I mean, again, it's going to be everywhere. We've kind of talked about this. It's seeping into other areas of healthcare. I don't know if we're going to go there today, but I mean, just how do you balance this enthusiasm that you have with this new technology? And I don't know, again, from the standpoint of some of these AI transponders where it'll take your meeting or take your patient interaction and lay it all out for you in action steps and things to, again, sign off for. But with the realities of budget, workflow, and even I think you've kind of hit on safety in a small hospital, where do you see concern and where do you continue to see enthusiasm for some of this investment and use?
the concern is always at the end of the day, we've got to not be operating upside down. We've got to keep the lights on. We got to keep people coming in and out of the door and be able to take care of them. And if this can allow us to, if an investment in this will allow us to more efficiently take care of a patient, and also maybe it, and again, this is coming soon, it's going to flag up that the patient is missing a preventative care. Well, and we go from micro to macro, but if I can detect a breast cancer early with a mammogram, the cost of the care of that patient goes down, right. And then those finances flow elsewhere. It's really tough to see at this point because we're so early in this, but those are the things that we already know can happen with good clinical stewardship to make sure we have prevention. New technology, depending on it, I mean, I'm virtually dependent on it at this point. It's not always perfect. It has bugs. It goes down. We have days where it doesn't. Mm-hmm. Those are few. Those are rare. Those are not something that's common at all. But at the same time, they do exist. And we talk about AI hallucinations. You can read about those. They're very real. And it's because the AI didn't quite understand something. But again, from a clinician happiness score, from a patient satisfaction, efficiency, and if at the end of the day, I'm not spending 1 to 2 minutes recording by typing or by dictation what I did with that 10 to 20 minute patient experience, and I have 20 patient experiences. That means all of a sudden now I'm +1 back to me. Like I can get one more patient in. I can squeeze the one in. The 3 o'clock, I picked up my kid from school. They've got a sore throat. We need to get in. Yep, squeeze them in. Let's do it. I've got the time. I can do it. And that's how that all works. Balancing safety. We've been doing this in medicine from the very get-go. What's the risk versus the benefit? Right. And we've got to make sure we keep doing that. We've got to be scrupulous when we're looking at what is this producing for us? How is it being programmed? What's influencing it? My EHR vendor is baking these things in. They are looking at this truly from the foundation of the electronic health record and how does it build up from there. And so there's a lot of care and caution being brought into that. And I am so stinking excited about it in case it's not obvious, but I'm also making sure we do it slow, we do it careful, we make sure that we're doing this correctly, because Hollywood's already putting out TV shows where the AI's messed up medicine. It's already out there. I'm not going to talk about the show, but I saw somebody sent me a clip of it. They're already on it. Okay. It's okay. We're going to show that we can do this better than Hollywood. I promise you that.
Oh, that's fantastic. Well, I can't wait to see that picture, maybe a documentary at some point, right? Just taking a step back, right? I mean, look at technology, everything. I mean, looking ahead, we've been talking about the future, right? AI, but just in general, looking ahead, call it 3 to 5 years, what's the biggest opportunity you guys see for the hospital?
Well, I think that, hospitals and clinics, we can't do it by ourselves. Just as the individual institution, we cannot do it. Even though we're as good as we are, we can't do it by ourselves. So we have to have those partnerships with, again, we talked earlier about the public health department or the ambulance service or, the school system and, our pharmacies in town. I mean, we need to bond together and to really, come together to address the community issues of the day. I talked earlier about the social determinants of health. That's something that is a wide net that has to be cast out there. And so if we're really going to address patients, I know we've had patients that have lived in squalor, basically, and they have mold in their where they're living, and they come into our emergency department. We address their breathing problems. We send them back home, and then they come back again.
Right.
So we've got to work together with our social agencies. And some of our, even our hospital foundation is starting to do more kind of funding towards the social determinants of health and help these individuals that, have their homes infested with bed bugs, for instance, or they have mold in the house. How can we help remediate that? So these are the things I think that we're really kind of starting to change our way of looking at some of these issues that patients are having. But again, we can't do it by ourselves, and we really are needing to get together with a lot of other agencies in the community to have a common front and address these challenges.
Yeah. Well, what does that look like in practice? So we talk about these partnerships and again with public health, and again, it's been a little constant throughout this entire conversation about how the things that happen outside of the hospital are more obviously indicative of health than the reactive nature and obviously many preventative nature of what you guys do. But I mean, what does that look like in practice to work with the health, like the health agencies and your emergency medical transportation departments? I mean, what does that look like? Is it a general cadence? Is it a meeting that's set or is it just ad hoc, right? Just having an open line of communication?
It's really all of those things. And it is evolving, I mean, frankly, almost weekly, definitely monthly, almost weekly, of what do we do in these scenarios. And for me, 3 to 5 years of medicine, it's going to look completely different than it did 5 years ago. I serve as the medical director for the local health department. I serve as the medical director for our 911, for our ambulance. And I'm using those opportunities to bring all those people together into this community health, this community, we call it community paramedicine. We call it population health. All of these things are going to begin to meld and come together because we see where we're overlapping but need to mesh instead of overlapping. That's the most exciting thing for me about the next 3 to 5 years of medicine. I see us looking as a community and our patients that we serve, and we're going to understand, okay, this patient has a mental health need, bang, they go down this pathway and they get involved in these programs. This patient has issues with food insecurity.
Systematic.
We're going to absolutely take our population health nurse, explain to them about, the food pantries and the different services they can get. We have folks dedicated to making sure patients can get access to health insurance if they currently don't have any. We help them walk through that. We have our nurse navigator for our cancer patients. And then we have, the community paramedicine where that patient, maybe they've been identified as we're coming to the ER, as Scott said, frequently. We then get a trained licensed person in their house who is seeing something maybe the patient isn't seeing. Maybe the patient doesn't even know it's a problem. And then we're going to help them to abate those things and figure out how to navigate that entire web of systems. That's what I see. That's how I see population health, preventative care maintenance, all of these things. They're going to meld. They're going to meld in the next 3 to 5 years. And then by the time I'm ready to retire in 20 or 40 years, then it's going to go, there it is. There's the thing that was the fruit of all the labor, all those fundamentals we put into place. Those are my goals.
Yeah, that starts with those partnerships, really starts with those partnerships and becomes a cohesive strategy, which sounds like you guys are already at the forefront of. This has been a fantastic conversation. I would be curious, even just with the time we have left, you talk about the next 3 to 5 years. I mean, we talked about the rural health transformation funds and what they're going to be suited to invest in. And, when I think of treatment and care, meeting patients where they are in a more virtual setting where need be, where do you guys see the hospital transforming from that regard to care, from care delivery? And maybe you're doing some of those things today. Talk a little bit about that.
Well, I know one of the things that we just finished a master site facility plan, and our board approved it here in January. And we identified areas that we think are really growing, that were really pinched for space. I mentioned earlier in our talk about our visiting specialists, and it's just jam-packed in there, and it kind of precludes us from being able to bring in some other specialists that we'd like to try to have here in our community. So we will be creating some more space for our visiting specialists. Same thing with primary care. We've got to develop some more space for that, and quite frankly, we can probably do a little better job of trying to how we interact with the patients while they're in our building, how we process them, and how they interact with us, and things like that. So there will definitely be some changes to our physical campus as it relates to going forward, and I think that that will again set us up better for the future. We do believe that our patient base, even though the county and our service area per se is not really growing, and maybe it might be shrinking a little bit, but we continue to see new patients every month, quite frankly, from around our service area. And we know that there are hospitals in Missouri that are struggling, and we don't know necessarily if they're going to be around in the future, but we want to try to do the best we can with our physical campus and the providers that we have coming here and our support staff to be able to accommodate those individuals that would choose to come and see us. So we want to be a welcoming site for all, really.
And Brendan, for me, I look at it as how am I going to do my job differently in the next 3 to 5 years? There's going to be absolutely no way to replace the connection of being in a room with a patient, holding their hand if they need it, and a lot of our physical exam features. However, I can do an EKG from a patient's watch and they can send it to me electronically. Blood pressure monitoring, glucose monitoring, all these things. Like, it's almost going to be like that hospital at home model. Some of these things have been floated out there. I see that happening more and more. I see it becoming something, especially as you get sort of those, I'm going to call them the late Gen Xers, the early millennials, those Zennials who are comfortable with a computer, but they're now, they've been at the forefront of technologies with what's in their home, and maybe they have various companies with these home AI type systems. I think it's going to become more and more of some of the things that my predecessors dreamed of, and they called it telemedicine.
Yep.
Those things, I'm going to be able to have a physical presence. We already do it now with telecardiology evaluations where you can listen to heart sounds. That's going to continue to develop, and it's going to look very different 5 years from now when a patient needs to see me. They're not necessarily going to have to always come into the office, and that's going to really accelerate. And there's going to be people who are going to prefer that as patients because it fits into their schedule better or what have you. But then we're still going to be there because we're going to make sure that when a patient needs to sit down and talk with Dr. Horine, we're going to be able to do that.
Right. Everyone's going to have a preference, right? I forget which commercial it is where the company, basically, there's always two types, right? The one that wants to be completely autonomous, but there's always going to be folks, whether they need to, because of the condition, because you need to see them in person, right, or not, you're going to be there. So as we wrap up, I kind of love this question because I want listeners to take something away that there's been plenty that's actionable here, but what is one mindset shift you believe rural healthcare leadership needs right now? And then what's one action that can be taken this month?
Well, to me, I keep getting back to that 80% of care that happens outside of our building, and that we're really needing to get together with again all these other agencies to try to address these community problems. We do a community health needs assessment every 3 years and addresses the top 3 things or so that are happening in our service area. And so we're working with other agencies again to tackle those things. So I think for me, that is something that it has to really continue, and people really have to provide the time to make that happen. I know it's one of the things that's easy to to kind of let that slide because you're so busy trying to make payroll or do a bunch of other things. But if we don't do that, then we're really not making the best use of our overall resources and doing the best thing for our collective communities.
Well, what I'll say to any healthcare leader who's out there who is wondering where do I begin? It begins with those relationships. That's what you do today. You make sure if it is a private practice clinician, if it is a private physical therapy that you've been working with, and maybe there's old bad blood somewhere. Maybe there's a situation that occurred. Maybe there was some hurt feelings. It's time to reach out. It's time to bury those hatchets. That's where you start today. And you start making sure you build those relationships in your community for the betterment of your patients. Even if you're competitors, you should be working on the benefit of the patient and doing those things to ensure that the services you're both providing, that you're doing it in a cohesive manner, that you have an information exchange between the two when patients need to float between two different organizations. That's the challenge. And the bottom line is it doesn't start with them. Every healthcare leader, it starts with you. You're the one who sets the tone. You're the one who makes the reach out. You're the one who sets the standard you want other people to follow. That's where you go. That's where it begins. It starts in the mirror. There's my advice for you.
Yeah. Wow. Well, I mean, again, relationships are paramount. I love how it's been a thread of the folks I've interviewed, and I can say that it's evident here how collaborative, even when in the face of, in some instances, competition, right? I mean, amongst healthcare providers, it's how collaborative you're willing to be with your peers, and we're all, everyone's trying to accomplish the same things. There's similar headwinds, and so I just appreciate both of you taking the time to come on the podcast. And I got to get up there and see this facility and see some of these things that you're investing in. And hopefully, Scott, catch you before you sail off into your sunset. But I really appreciated the conversation, guys. And, we'll be in touch.
All right. Thank you, Brandon. Appreciate it.
All right.
Sounds good, Brendan. Thank you so much.
See you guys. Bye.